Assalamualaikum and very good day to everyone. We are group number 9 and today we will present about the most common form of breast cancer, ductal cell adenocarcinoma. Before that, let me introduce my team member. I'm Sharifah Mahfuza binti Said Mahfuzat and my friends Muhammad Harif Aizat bin Abdul Halim, Norziah binti Abdul Aziz, Muhammad Anis bin Muhammad Rasni and Nur Syahidah binti Tayurman. So, let us start with our main topic. What is invasive ductal carcinoma? Invasive ductal carcinoma, IDC, also known as infiltrating ductal carcinoma, refers to the uncontrolled growth of cancerous cells originating from the ducts of the breast tissue. The cancer cell may penetrate through the ductal wall, invading the stroma. Okay, let me explain a little bit about the anatomy of the breast. The breast is composed of mammary glands surrounded by the stroma. The mammary glands are made up of the 12 to 20 lobes, each of them containing many smaller lobules and even smaller alveoli. The alveolar lobules and lobes are connected through a network of the milk duct that drain the milk produced during lactation to the areola. The development of IDC originating in this milk duct. Okay, look at this picture first. Maybe we can give you some idea about the topic we are discussing today. This is normal duct. This is ductal hyperplasia, atypical hyperplasia. It is ductal cell carcinoma in situ and invasive ductal carcinoma. So, we move to etiology of IDC. IDC occur when genetic mutation or genetic damage in the DNA of breast duct cell that lead the cell to appear abnormal. The two breast cancer genes are known as BRCA1 and BRCA2, associated with an increased risk of IDC. Actually, BRCA1 and BRCA2 are genes everyone has, but some people have mutation in this gene that can greatly increase the risk of breast and ovarian cancer. These genes are known as tumor suppressor, and when they functioning normally, they help maintain cell growth. But when harmful mutations are present, cells have the potential for uncontrolled growth. IDC is associated with certain risks including age, mostly female more 55, gender, 99% of female and male, the rest, family history, medical history of breast cancer or benign breast disease, radiation exposure, dense breast tissue, long-term use of hormone replacement therapy, exposure to diacetyl bestrol, obesity, alcohol, and tobacco use. There are several warning signs and symptoms of breast cancer that are worth paying attention to, like lump in the breast, thickening and redness of the skin of the breast, swelling or change in the shape of the breast, localized persistent breast pain, tipping or retraction of the skin of the breast or the nipple discharge, other than breast milk, scaly or flaky skin on the nipple or ulceration on the skin of the breast, lump in the underarm area. So, I pass to the next topic to my friends.
Sorry. Good morning, everybody. My name is Nazia. I will present about the pathogenesis for this breast cancer. Okay, breast cancer is caused by clonal proliferation of ductal cell with multiple genetic aberration caused by hormonal exposure and inherited susceptibility genes. There is two types of estrogen receptor, which is alpha and beta. Alpha estrogen receptor, we can find it at breast, ovaries, and endometrium, whereas the others, which is beta, we can find it in kidney, brain, lung, and several other organs. Both uh, estrogen receptor can carry the DNA binding domain and exist in nucleus and cytosol. When the estrogen enter the cell, it binds with the estrogen receptor, and this complex will migrate into the nucleus and lead to the production of transcription protein that induces changes in the cell. Therefore, due to the estrogen proliferation properties, the cellular stimulation can have negative consequences in patients expressing large quantities of this receptor intracellular. Role of estrogen in breast cancer, there is a two roles which can give the genotoxic effect of estrogen metabolite via generation of radical. This is initiator of the cancer, and the other one is the hormonal properties of estrogen, which can induce the proliferation of cancer as well as the pre-malignancy cells. Role of human epidermal growth factor receptor 2, HER2. HER2 belongs to the epidermal growth factor receptor EGFR family of proto-oncogenes and currently is not known to have a ligand. However, the protein has been shown to form clusters within the cell membranes in malignant breast cells. The mechanism of carcinogenesis remains largely unknown, but overexpression is associated with rapid tumor growth, shortened survival, increased risk of recurrence of surgery, and poor response to conventional chemotherapeutic agents. This is uh, the graph of breast cancer pathogenesis and histologic versus molecular subtype. Hold on. This picture shows the progress from the beginning of the breast cancer in the cell in the gene of the breast cell itself. We start with the pre-invasive cancer and for ductal cell and lobular cell, because under breast cancer we have two common breast cancer, which is ductal and lobular according to the cell type. Once we diagnose this cancer, whether it is ductal or lobular, we do the molecular subtype for ER, PR, HER2 to detect more definitive diagnosis. And from here we can see the prognosis of the cancer, whether it is good or poor. According to this picture, we can see that if the receptor expression of HER2 is more on the luminal A, it shows that the prognosis is very good. The second slide shows the reaction into the cell also. Okay. When the estrogen receptors start going to be abnormal, it is when we can see in benign proliferation changes. Okay, and then under the atypical hyperplasia, the gene start to lose the tumor suppressor function as a P53. Okay, next. This one, okay. This slide show um, the progress of the cell cancer. Whether it can invade the basement membrane of the stroma cell. So when the cell is starting invading the stroma cell, the function of uh, the cell is starting to lose. The mutation starts at the proliferation delay, where it lost the apoptosis. After that, the genome instability, loss of growth inhibition also occur during this period. Then it goes to the atypical hyperplasia and carcinoma in situ, where the cell self-sufficient growth, angiogenesis, and limitless replication occur. After that, when it comes to invasive carcinoma, the tumor cell start to invade the stroma cell. Okay. Other than there also another reason why the breast cancer can occur in the patient. One, the cause is because of the hereditary breast cancer. About 12% of breast cancer are due to the inherited susceptible genes. Major susceptibility genes for hereditary or familial breast cancer are BRCA1, BRCA2, TP53, and CHEK2. They are tumor suppressor genes which play role in DNA repair and maintenance of genomic integrity. Mutation in BRCA1 and BRCA2 are responsible for 80% to 90% of single gene familial breast cancer and about 3% of all breast cancer. Now I will talk about BRCA. BRCA1 is a long arm chromosome 17, which is 17q21, autosomal dominant trait which high penetrance, a role in transcription, cell cycle control, and DNA damage repair. 90% of lifetime risk of breast cancer, 40% lifetime risk of ovarian cancer. It is a basal-like breast cancer. Meanwhile, for BRCA2, it occurs at chromosome 13, which is 13q12.3. It is autosomal dominant trait and has a high penetrance also. Role in DNA damage response pathway. The carrier is male, 100-fold increase over the risk in the general male population. It is found in invasive ductal carcinoma. BRCA1 also shows medullary features, a syncytial growth pattern with bushy margin and lymphocytic infiltration. It is high-grade, polydifferentiated type, hormone-negative receptor ER HER2 negative, and employed increased expression. We can find it in early age of onset, a high prevalence of bilateral breast cancer of and the presence of associated cancer. BRCA2 is usually we found it in well-differentiated cancer type. It's commonly hormone receptor positive and more often in estrogen receptor positive. Early age of onset, we can find it, and a higher prevalence of bilateral breast cancer and the presence of associated cancer. I pass this slide to Muhammad Anis. Thank you.
Hello, good morning everyone. My name is Muhammad Anis. So I just want to continue about the pathogenesis part. So my part, I will talk about the other genes account for less than 10% of hereditary breast carcinoma. So in here, the TP53 mutation and CHEK2 mutation in only 8%, but somehow the P10 and STK11 and ATM mutation in less than 1%, which is still be detected. All these genes have role in maintaining the genomic integrity. So the first one, ATM sense DNA damage, and P53 and CHEK2 cell cycle arrest, and BRCA1 and BRCA2, and CHEK2 function is repair of double-stranded DNA. So hence, because of that, impact function of any one of the gene can cause genetic damage. Next slide. So we talk about the sporadic breast cancer. The major risk factors for sporadic breast cancer are related to hormone exposure, which are influenced by gender, age, reproductive history, breastfeeding, exogenous estrogen, and also other risk factors are reduction exposure and exposure to chemicals with estrogen-like effect. Estrogen also causes cell proliferation, especially during puberty, menstrual cycles, and also pregnancy. The cells with defective DNA also undergoes proliferation under the influence of hormones. Exogenous estrogen or endogenous high level of estrogen also has similar effect. As example, hormone replacement therapy and postmenopausal functioning ovarian tumors, granulosa cell tumor produce high estrogen levels, and also long-term use for oral contraceptives. And lastly, the estrogen given as a treatment for prostate carcinoma. So we talk about the molecular part, the molecular mechanism of carcinogenesis in breast cancer. There are three major genetic pathways for carcinogenesis, which are first, the dominant pathway. The second one, pathway associated with application of HER2 gene on chromosome 17q. And lastly, the third one, pathway independent of ER-mediated changes in gene expression and HER2 gene amplification. Dominant pathway, the individually inherits germline mutation in BRCA2, constitute only 50 to 60 cases. It depends on the cases. And also, these tumors are often associated with first loss of chromosome 16q, gain of chromosome 1q, and mutation of PIK3CA. So the precursor lesion for these subtypes are flat epithelial atypia, atypical ductal hyperplasia. These tumors are ER positive and HER2 negative. ER positive tumor are also termed as luminal, as what my friend presented just now. There are two types, and they resemble normal breast luminal cells in the mRNA expression pattern. So the pathway associated with application of HER2 gene on chromosome 17q, they constitute only 20% of cancers. They are HER2 positive cancers which may be either ER positive or ER negative. Most common breast cancer in patients with germline mutation in TP53. And lastly, precursor lesion for the subtype is atypical apocrine adenosis. When we talk about the pathway independent of ER-mediated changes in gene expression and HER2 gene amplification, there are tumors constitute 15% of breast cancer. They are ER negative and HER2 negative. Tumors are often associated with germline BRCA1 mutation and TP53 mutation. Tumors have basal-like pattern of mRNA expression which is similar to normal myoepithelial cell expression. Neoplastic change in epithelial cells depends on the interaction with stromal cell, indicating the alteration in the function of stromal cell, and crosstalk with epithelial cells are associated with tumor genes. And I will pass over to my friend to conclude about the pathogenesis part. Thank you.
Okay. As in summary, for pathogenesis, this is the summary of the what my friend and myself explained just now. In breast cancer, we have two types, which is non-invasive and invasive. We have a lot of type of breast cancer here, and the cause according to the genetic, demographic, the age, the prolonged estrogen exposure, also about the medical history and lifestyle also can cause the breast cancer. Explain it in here. I think I will not explain it more on this. Uh, now I pass the now I pass to my friends for the diagnosis.
Okay, Assalamualaikum and a very good day for everyone. So I will talk about diagnosis. Diagnosis can be categorized by into early diagnosis and diagnosis itself. So early breast cancer diagnosis can decrease the rate of death. Women should perform monthly self-examination to screen their own breast. For persons that are 15 years old and above, a physical checkup is recommended every year. Physical examination by a health professional every 1 to 2 years for persons aged 20 to 49. Next one. So for breast self-examination that can be done by ourselves, for male or female, it's not a problem because nowadays male also can have breast cancer. So this is the step that can be done by manual inspection by ourselves. So no single test can detect all breast cancer early, but many people report that performing a breast self-examination in combination with other screening methods can increase the odds of early detection. Breast self-exam or regularly examine your breast on your own can be important way to find breast cancer early when it's more likely to treat it successfully. Next one is okay. This is breast clinical examination. A clinical breast examination is conducted by a medical professional who has certified to identify many different types of abnormalities and warning signs. So, in other words, we can go to specialists that have a certified to check ourselves that we have that symptom or not. Yes. Okay, for diagnostic tests, uh, there are 5 diagnostic tests that can be used for diagnosis method, which is mammography, MMR, ultrasound, needle aspiration biopsy, incision biopsy, and also magnetic resonance imaging MRI. Okay, for MMR, mammography, it is gold standard for breast cancer. MMR methods can be MMR is a procedure which each breast is compressed by the tools, uh, as we can look at this picture, which this procedure. This is a craniocaudal view from up front. We can view it, and then this machine will capture our breast, and next picture will interpret this picture will interpret that which our breast can be a cancer or not. So this is the image that captured by MMR. And only only a specialist can read it and to determine that there are cancer or not. Okay, next one. So for the next diagnostic test is ultrasound. Breast ultrasound use sound wave and their echoes to make computer pictures of the inside of the breast. It can show certain breast change like fruit-filled cysts that can be harder to see on mammogram. So ultrasound is the alternative that can be used other than mammogram. So it needs uh, uh, a doctor or a specialist to check the whole of a breast to find the cancer or abnormal change in breast. Uh, Other than mammogram, it's captured by a picture. So for ultrasound, it must be found by a specialist. And next step is fine needle aspiration. So from the ultrasound, the changes can be aspirated in this procedure. Fine needle aspiration is a small sample of breast tissue or fluid that aspirated with a tiny hollow needle during fine needle aspiration. And the sample is examined for the presence of cancer cell. So for this FNAC, this is a screening method, not a confirmation method. So, but it can help to search or screen for the cancer cell. Then it will examine under the microscope to search the presence of cancer cells. Next one is excision biopsy. So what is excision biopsy? It is a surgical technique it's a surgical technique that remove a lump from your breast. This tissue biopsy will be sent to lab for further testing. In addition, it's used to using specific stain which is hematoxylin and eosin HNE stain to to apa, to to look under the microscope. We use HNE stain. Next one. This is the figures that we can look under the microscope, which is normal milk duct. So basically, the nucleus will be colored by purple, and the cytoplasm will be pink one. So this number 2, the ductal carcinoma in situ, DCIS cancer cells inside the duct. So we can look at the difference between cancer cell and normal cell here. And the third one is invasive ductal cell, IDC, cancer cell spreads out the duct. In other words, spreads or spread everywhere. Okay, next one. So for the last diagnosis method, we can use magnetic resonance imaging MRI. So for breast MRI are used to determine the severity of breast cancer. It's also used to screen for breast cancer in people who are deemed to be at high risk for breast cancer. So it means that this technology can search the severity and also can predict at the high risk person. So that's all for the diagnosis, and I will pass it to Nur Shahida.
Okay, Assalamualaikum and good morning everyone. So let's move to the last slide, which is the treatment. Basically, for the treatment, it will be decided by the physicians and the doctors itself. So for the basic treatment, the first one, the most common one is the surgery, which is there is two types, white adhesions and mastectomy. For the white adhesion, it's just a removal of a small amounts of the lumps, and the mastectomy is the overall of the breast lah. Okay, so the second one is radiotherapy, which is this one is recommended for the patient with invasive cancer after WLE, means needs to do WLE procedure first, then we move to the radiotherapy for the next precaution step. And then chemotherapy, there is two types, adjuvant therapy and neoadjuvant therapy. And then last but not least, for the other treatment, it is endocrine agent, tamoxifen, anastrozole. The second one is the reconstruction option, which is the tissue expander or implants, latissimus dorsi flap or tram. Okay, next. Okay, this is our reference. And last but not least, that all from us. Thank you.